Good morning and welcome. My name is Kathy Colville. I'm the president and CEO of the North Carolina Institute of Medicine, a health policy organization chartered by the North Carolina General Assembly to provide nonpartisan, evidence-based policy recommendations for the health challenges facing our state. I bring you greetings on behalf of our team at the NCIOM and our wonderful colleagues at the Duke-Margolis Center for Health Policy. Today's webinar is a hot ticket. We are excited that hundreds of people from across North Carolina and the United States are joining us today for this event focused on the early lessons from North Carolina's Healthy Opportunities pilots, part of North Carolina's Medicaid managed care efforts to adopt a whole person care approach to buying health and by integrating social needs and clinical services. If you'd like additional context and background on the Healthy Opportunities pilots, please refer to the document that will be magically dropped into the chat right now or in just a few minutes. For a deeper dive into this issue, I would direct you to the September 2019 issue of the North Carolina Medical Journal. This issue is packed with history and the context of Medicaid transformation in North Carolina, and that will go into the chat as well. I'm going to quote just very briefly from then Centers for Medicare and Medicaid Services Administrator Seema Verma in her commentary in Health Affairs when North Carolina's 1115 waiver was approved in the fall of 2018. She said, "We know that behaviors and other determinants of health, like where we work, live, learn, and grow, are all factors in our overall health and well-being. As we seek to create a healthcare system that truly rewards value, we must consider the impact that factors beyond medical care have in driving up health costs. That's why many states are beginning to think about better ways to address the root cause of chronic illness. As part of this demonstration, North Carolina will implement a groundbreaking program in select regions to pilot evidence-based interventions addressing issues like housing instability, transportation insecurity, food security, and interpersonal violence and toxic stress." I chose to quote Administrator Verma to highlight one of the unique aspects of this program's context. North Carolina's 1115 waiver and the Healthy Opportunities pilots were approved by a Republican federal administration, designed and drafted at the state level by an administration led by a Democratic governor in a state with Republican legislative control. Other contextual aspects that would be important to note are that this 1115 waiver was also the beginning of a transformation to a Medicaid managed care payment system, and that North Carolina remains a non-expansion state for Medicaid, although expansion has gained strong support from several key legislative leaders in the past months. Briefly, then also on the structure of the pilots, you can also see the chat for a link to the Healthy Opportunities website. There are 3 of them in different regions of our state. Each involves a complex network involving the prepaid health plans, also known as PHPs or managed care organizations, the network leads, and human services organizations and others. And they work off of a standardized fee schedule for services related to housing, food, transportation, toxic stress, and other social needs. And we'll also have a link to that fee schedule in the chat. If we get too excited about all of our jargon and abbreviations that we're using with this, one of our team will really try and remember to put some translations into the chat. Our goals for this time together are to reflect on some cross-cutting themes of these early stages of design, planning, capacity building, and early implementation, to hear directly from those who are in the thick of it, and to try to see around corners and anticipate the next phases of this important work. I want to remind all of our panelists, presenters, and our audience today of the guts, courage, and care shown by the people that you're going to meet today. This is really groundbreaking work. There's no script, there's no checklist for anyone to follow. We all get to learn from them, and we honor their honesty in sharing their lessons from the trenches on this work. The next 90 minutes are divided roughly into 2 parts, and the first part will focus on state-level perspectives with a presentation from the Duke-Margolis team and a panel of voices working on design and implementation of the state-level infrastructure. We're going to take a quick break after that and return for the second half, which will be focused on regional and community perspectives. A few notes. This is a little bit different from a regular Zoom meeting. You won't be able to submit questions via the chat, but you'll be using the Q&A function. Please submit any questions for the panelists and we will get to those as time permits. I'll note that this webinar is being recorded and that closed captioning is also available. If that is helpful to you, please click where it says live transcript or CC, likely at the bottom of your screen. To jumpstart the day, I'd like to introduce Will Blesser from the Duke Margolis Center, where he's the Assistant Research Director of Healthcare Transformation for Population Health, Social Needs, and Health Equity. Will's going to give an overview of major research findings from Duke Margolis's work to understand practical and timely implementation considerations and policy recommendations from studying the pilot's planning, capacity building phases, and early implementation. Thank you, Will.
Thanks, Kathy. I appreciate that introduction, and we're excited to share an overview of some of what we've found over the last 2 years. Just would like to note that we received funding from the Robert Wood Johnson Foundation to help generate these timely implementation and policy recommendations. And just quick context, we conducted over 40 interviews with folks involved in planning or implementing the pilots, as well as some folks from other states running similar programs. We reviewed planning documents, we convened subject matter experts, and we had 2 focus groups with people who actually received services in the pilots, and so that's informing this talk. So through our research, I'm going to walk through the 5 implementation and policy themes that we identified, and why don't we just jump right in. So for our first theme, we learned that varying program goals and design philosophies greatly impacts the scalability, success, and evidence generation capabilities of programs to address health-related social needs. We heard interviewers recognize that the pilot programs has several goals. One goal is to evaluate the impact that Medicaid coverage of select evidence-based interventions to address social needs has on health outcomes and costs, to determine whether any should be scaled or further integrated into the healthcare system. And at the same time, the pilots also aim to strengthen the capacity and sustainability of community infrastructure and HSOs. And we learned that these goals, which are both really important and they do complement one another, but sometimes can be at odds a little bit with how they play out across the program. Second, the state gave flexibility to the network leads to design their human service organization networks, which led to innovative variations in network design across the regions. Each network lead tailored their governing bodies and their HSO networks to build from their historical context and existing community relationships. And finally, we heard that there's opportunities to further improve some covered services and fee schedule details. For example, some interviewees thought that some service definitions could be expanded to capture the true scope of work that HSOs provide to close the loop, and others suggested the fee schedule could be updated to encourage bundling of complementary services such as housing navigation that precedes other services. A couple implications for policy from these findings. Just wanted to note, of course, that the Section 1115 waiver policy route that this program was made possible by is a very promising avenue to address health-related social needs through Medicaid in states, but we do want to note that this can be highly influenced, of course, by a varying state policy context. For example, Section 1115 demonstrations have a budget neutrality requirement that requires them to be neutral to the federal government, which means that the success of the programs will depend on whether or not we can generate savings that offset the expected costs of the pilot program. Second, different high-level goals and design philosophies for these programs can translate to trade-offs in building infrastructure, generating return on investment, and program flexibility. We'll talk a little bit more about the business case later. One key aspect of program design is centralized versus decentralized. And for the pilots, the state centralized program design that they utilize, but they also created a decentralized structure within the networks, allowing for regional customization. Lastly, we heard that short-term sustainability of the pilots is dependent on a creative and comprehensive evaluation. So elements of the CMS-funded evaluation, which is being led by the Shep Center for Health Services Research at UNC Chapel Hill, and we'll hear from the lead later, can guide others interested in developing and evaluating similar programs. Importantly, the design includes rapid cycle evaluations that look at short-term changes in outcomes and healthcare utilization to inform early program and policy changes, and evaluations of patient-reported outcomes and experiences with the program. We did just want to note that looking forward, it will be important for CMS to try to expand the scope of what they require in their demonstrations so that we can capture a little bit of a multi-sectoral effect. For our second theme, we learned that aligning new and existing programs, policies, and infrastructure can help effectively and comprehensively address health-related social needs. So one way we learn to increase program effectiveness resources, and sustainability is to ensure that all the existing infrastructure in the area is being leveraged. Interviewees shared examples of key community partners that could be better engaged moving forward, including community health centers, schools, faith-based organizations, and local departments of social services. Interviewees also shared opportunities to improve beneficiary awareness of the pilots. So one example would be North Carolina during the COVID-19 pandemic emergently stood up a program called the COVID-19 Support Services Program, and they deployed a community health worker program that they had already been building statewide in order to reach people, and that could be leveraged in this program. Some implications that we learned from speaking about folks about local infrastructure is that, of course, there are many stakeholders involved, and programs to address social needs often need to overcome the cultural divides between many sectors. Engaging trusted and accessible organizations in the communities can help meet people where they are and facilitate equitable access. And then finally, Medicaid programs, of course, are one of several ways for people to access social support services. And in many places, these programs have separate enrollment processes, and there's opportunities to learn from other states that use express lane eligibility to simplify the enrollment and renewal of Medicaid and CHIP and social services within one program. Our third theme, we heard about the importance of building a business case for scaling and sustaining the capacity of these community-based organizations. Again, in the pilots, they call them human service organizations, or HSOs, so you'll sort of hear me use both terms. Interviewees shared that the pilots present a vital opportunity to invest in HSOs to build their capacity. Of course, there was a capacity building phase in the pilots, and the associated funding provided HSOs with an opportunity to make investments necessary to succeed. They were intended to help increase community resources in traditionally underserved areas more broadly than they existed. We heard from HSOs participating that they have a variety of capacity and experiences. For some, the pilots presented an entirely new model of service delivery. They were expanding into new service areas. They were receiving new funding and reimbursement and building new partnerships, while other HSOs had a lot of prior experience and were simply expanding the type of services that they traditionally offer. Some interviewees shared that there are opportunities to better accommodate this range of HSO experience to foster equity moving forward. And lastly, we heard that there are opportunities to increase support for the time and resources that HSOs spend setting up and delivering the pilot services. In the program, these are referred to as administrative fees, and they can vary depending on the services being delivered. And that was something that we heard from folks. Some policy implications, we learned that there are three major considerations for policymakers seeking to develop the business case to drive sustainable success of CBOs. First, programs to address social needs must fill a business niche that builds upon and adds to the system capacity rather than, quote, crowding out existing capacity. This means that it is important that HSOs are able to continue to provide services for the pilots, but also continue to serve other local populations that are not eligible for the pilots that they are already serving or should be serving. Programs that provide upfront funds dedicated to building new CBO capacity, which the pilots are doing, and then also additionally collecting data to periodically monitor CBO service delivery across service lines can help avoid crowding out. Second business case consideration is creating a model that's profitable to HSOs, but also generating an ROI to payers. So through the pilots, North Carolina became the first state to design a Medicaid fee schedule that defines and prices interventions to address these domains that we talked about today, which is designed to provide HSOs with transparent payment rates and encourage HSOs to provide services through the program. But we do want to note that the longevity of the program will be dependent on the ability of that fee schedule to generate budget neutrality. And finally, for sustainable business case, we wanted to note again that this would ideally involve more than Medicaid dollars. One example I mentioned earlier, the North Carolina Support Services Program for COVID, they used a combination of CARES Act funding and state legislation appropriated funding, which gave them the regulatory flexibility to make changes much more quickly than the current CMS design allows. I would also like to note, and we'll talk a little bit about this in a future theme, but the pilot's success is being bolstered by generous support from local foundations. Our fourth theme, we learned that supporting health policy programs to address many sectors like this requires a commensurately sophisticated training and TA program. So we heard from interviewers a desire for different types of technical assistance that could vary by the stakeholder type. For example, interviewees shared that for several housing services, beneficiaries' landlords must sign consent forms, and having standardized templates for such forms for all HSOs and network leads to build from could help streamline efforts and reduce administrative burden. We also learned that there's opportunities to expand and align TA and training across the state. And I mentioned earlier that network leads had a lot of flexibility to tailor their programs. So that is something that we saw. For example, Impact Health is working with a local healthcare network to provide technical assistance, focusing on performance improvement, HSO development, and value-based payment technology. Lower Cape Fear is working with a local medical center, a nonprofit, and a university to work on cultural competency, implicit bias, and program evaluation. And Access East is also partnering with the local university to develop a readiness assessment and working with a local area health education center to provide training on cultural competency. And lastly, just back to the local philanthropic support, I did want to note that the Blue Cross Blue Shield Foundation of North Carolina and the KP Reynolds Charitable Trust funded the CareShare Health Alliance to establish a Pilots Resource Center, which is providing statewide TA. Some implications would be learning from other similar states and programs, and I just wanted to call out Oregon Health Authority's Coordinated Care Organization program, their TA program, and that this is a program that allows spending on health-related services that include services similar to pilots. They offer webinars, office hours, guidance documents, and then California's CalAIM program provides a virtual marketplace of programmatic documents for offering TA and training for community partners. And our last theme, the last minute I have here, we learned about considerations for using data and technology to support complex programs like this. So we wanted to acknowledge NC Care 360. It's a technology platform that's central to the implementation of the pilots. It was developed through a public-private partnership and is available statewide, combining a variety of health, demographic, and social data. And for the pilots, this program is used to facilitate eligibility screening, enrollment, closed-loop referrals, and invoicing. I just wanted to note, of course, that there are a lot of challenges when you have a program that spans many sectors. There's also legal and regulatory, multiple legal and regulatory requirements from different sectors. So due to the cross-sectoral nature of the pilot services, storage and use of beneficiary data has to comply with many sets of regulations, which could include VAWA, FERPA, FVPSA, in addition to HIPAA. And interviewers expressed a little bit of concern about how NC Care 360 might comply with regulations related to interpersonal violence. Granted that there's a lot of high-level protections against to protect folks who have the, data in the system related to interpersonal violence. So some implications just to close thing out. There are other examples in the field to learn from. One is CrossTX, which is another tech platform that complies with multiple regulations across the health and education sectors and is used to facilitate behavioral health integration. And finally, there's other health policy efforts to facilitate and standardize the exchange of data related to social determinants of health, such as the Gravity Project, a private-public initiative to help develop standards for using and exchanging social needs data within the health realm. And San Diego has created a community information exchange system allowing for real-time data exchange between community, social service, and healthcare organizations. So I want to wrap things up so we can get to our exciting first panel. But I did want to note, I know we have a range of policymakers today from federal government as well as other states and commercial payers. I would encourage you all to reach out to us if you're interested in developing programs like this. We want to help. I'm going to turn back to Kathy, and thanks all for the opportunity to share our research.
Great, Will. Thanks so much. That's a really nice framing for our first panel, where we're going to focus on all of the lessons learned for designing. I think I heard first of its kind multiple times in your presentation to do this at scale. I want to welcome Will to our panel on state level perspectives. And Will is joined by Seth Berkowitz, the Associate Professor of Medicine at University of North Carolina at Chapel Hill, by Laquana Palmer, the Program Director of NC Care 360 at the Foundation for Health Leadership and Innovation, by Amanda Van Vliet, who's the Associate Director for Innovation for North Carolina's Medicaid Strategy Office within the North Carolina Department of Health and Human Services. And finally, a huge warm welcome to Ayanna Simon, who is filling in for someone who became ill this morning. I think Ayanna's had approximately 15 seconds to prep for today, but she's ready, willing, and able, and we appreciate that. And because of that, and Ayanna is the Healthy Opportunities Program Director for Carolina Complete Health, one of the managed care organizations or prepaid health plans in North Carolina. And because of that, we also have Faith Samples, who is acting as backup and helping to be another perspective on PHPs. So information about our speakers can be found in the meeting agenda packet, and that will be placed in the chat as well. And again, we welcome all of you panelists to this. So to kick off this session, I want to turn first to Amanda, Laquana, and Ayanna. And I'm just going to ask you as a reminder to try and keep your answers to 1 to 2 minutes rather than 1 to 2 hours, but I think each of you could write a dissertation on this work so far. This is incredibly exciting work. And at the same time, being the first means a lot of creativity and problem solving is necessary to occur throughout all of this design and implementation phase. We want to hear from you about a challenge, something that you've faced, you might not have anticipated, or maybe you did. What has been one important challenge so far where you have arrived at an innovative solution that you think is a helpful lesson to share? Laquana, can we start with you?
Sure. Good morning. Thank you for the invitation. Just to think about some of the challenges that we experienced with NC Care 360. First of all, before we even began to work on the pilots, we began to work on NC Care 360 with making sure that it was a statewide implementation. And when thinking about that, all of our different systems, and because it is cross-sectional, they have unique needs. And with those unique needs, each organization, each agency, each program has a specific want and need that they want to experience when they are using a technology platform. So with that in mind, there were other, issues that may have, come up during that time as well around just staffing and resources. So when you're thinking about all of these organizations and you're thinking about something that is being implemented during COVID and the height of COVID, many of these organizations have business practices that had not been implemented. They were missing staff members, and then sometimes they were also missing resources. And because we had a system that was so strained across the state, we had to make sure that we were responding to all of those unique needs.
Thank you for that. It all looks so clear on paper, doesn't it? And then there's so much work to be done to just truly knit together. And I think, as you mentioned, finding these unique cases that need a specific solution.
Absolutely.
Amanda, what about you? Talk to us about a challenge that you all had to put heads together and figure out a different way.
Yeah, thanks. First, I really want to thank all of our partners that have helped us with this, our HSOs, network leads, CINs, AMHs, health plans. There have been a lot of opportunities and challenges along the way, and just want to recognize that they have helped us figure out so many of them. So I think one of the biggest challenges that we, saw up front, but has become a lot more nuanced, is invoicing and payment for HSOs. We're essentially asking them to change a lot of their business model from relying on grant funding to then asking them to do retrospective service-based reimbursement that they are not really set up for. So we tried to address this through a range of ways. One, I think the capacity building funds were really helpful up front to get them some startup costs to make initial investments. But two, we've dealt with everything from really high level design challenges to like pretty nitty gritty details. So one, I think originally we were considering having our network leads make the payments to HSOs directly, and we ultimately decided to have our health plans make the payments since they already had the existing infrastructure set up to do that, which I think was a big benefit to us and allowed us to roll it out more quickly. That said, we also really decided up front to try to meet the HSOs where they were as much as possible and rely on invoicing rather than claims, so that we didn't require HSOs to have claims processing systems in place and technology that they may not have likely had. That said, our health plans aren't used to relying on the scale of invoices. They're used to relying on claims. And so our health plans have really taken invoices and translated them to claims that they can then submit as encounters to the state. So they've done a lot of work there. We did decide to use NC Care 360's invoicing technology to try to make that as easy for HSOs as possible. And I know that they are working on a solution to translate those invoices to claims as well, which will be helpful. And then lastly, I'll just say more recently, we have been getting much more into the weeds and seeing even with remittance advices, for example, that are sent from health plans to HSOs. Our HSOs have been telling us that they haven't been necessarily receiving all of the information that they may need to track payments. And so we've just stepped in a little bit more to specify kind of exactly what's needed on those and kind of facilitate between our health plans and our HSOs to make sure that all of the payment information is getting to them. And so again, just want to thank all of our partners because I feel like they've all done creative solutions in this space. So thank you.
Great, Amanda. And I'm just going to tease out, you said that so well, but that first part, just to not underestimate what it means for a human services organization to go from writing a grant to be able to hire a staff member to do a certain amount of a service to a unit by unit accounting of this, how critical that is. And then also just, I love the level of detail in talking about what that meant to have an invoice versus a claim, right? This is the realities of trying to knit together systems that we think just belong together naturally, but have developed these different ways of doing the work. And how cool that you're figuring out a way to put those things back together. Ayanna, you bring such a valuable perspective. And again, we appreciate you being with us with such short notice. Talk to us about a challenge that the PHPs have faced or that Carolina Complete Health in particular, and where you've figured out a solution for that.
I am going to piggyback on exactly what Amanda said. We have had to really think about a creative way to move from typical provider claims to atypical provider to invoicing. The technological needs to stand this up. Creating different solutions. How do we feed this into our current claims system when we move there? What does the communication look like between us and the human service organizations and the network leads and who's responsible for what? There's been a lot of discussion even about the responsibility of the care manager in this pilot and who's responsible for the healthy opportunities portion. Some of our members will have care managers who are assisting but making sure that they have access to healthy opportunity specific services. But then all of the rest of their care management is done with the care manager who they're familiar with, which is what we want. But in some cases, there is that duality, which we're just trying to work through how to identify the appropriate care manager, making sure that everybody is working together and as seamless as possible. So when you ask for creative solutions, we are still wrapping our brain around that and just trying to figure out how to be agile and change as things change. Fortunately for us, Carolina Complete Health is only operating in one of the 3 pilot regions. So we have the luxury and we already have a connection with Community Care of Lower Cape Fear because they provide our care management. So we haven't had to scale to the rate that others have had to do. But still that work of trying to figure out how to pivot, how to change, how to fit this model into what we're used to providing for medical-based claims, I would say has been one of the things that we are still working through. So, but our members are definitely benefiting from the program, and we're doing everything we can to make sure they do. So thank you all to Amanda and to LaQuana for all that you all have done to help make us as successful as possible.
Yeah, it's really collaborative. I mean, you get this sense that there's a community of people learning. We really appreciate this window, and we're going to come back to the 3 of you, but I want to go to Seth. Seth has a different role in this. He gets to be the person who has that wide open window as the CMS, leading the CMS evaluation of this very complex cross-sectoral health policy program. Seth, walk us quickly through the design and the goals of your evaluation, and then how it will influence the final design of the pilots and evidence for the field, and any recommendations you'd offer for other states considering similar programs.
Sure. So, it's a complicated design, as you alluded to. Definitely could write. I think the CMS approved document goes well over 100 pages, so a lot to spend time on. But I just want to highlight a couple of things. One that, and I think this is applicable to other states to answer your last question, is to really have a sense of what the evaluation, I'll say, philosophy is, and by that I mean sometimes you're evaluating a program where you've got what you think is pretty much the final version of the program. You want to implement it with fidelity. You know exactly what you think should be done. And you want kind of a yes, no answer. Did this work or not? That's not what we have here. We specifically call it the pilots because these are pilots. These are learning opportunities. And so when your goal in the evaluation is not to sort of give a yes, no answer of a program that's already been designed from soup to nuts, but instead to learn what works, to make modifications on the fly and things like that, you design the evaluation differently. And so that guiding philosophy has really influenced a lot. I'd say a key aspect, or I'll say two key things that really go into that are, one, and Will alluded to this earlier, the idea that instead of saying, every area is going to do this type of food insecurity intervention because that's the one that we think is going to do, and instead say, you know what, these are people who work together a lot, who've developed a lot of local knowledge and insight over time. These communities know better how to address food insecurity in their community than a top-down thing is going to be. And so different regions will have different organizations, both, different people in the organizations, but also different types of organizations with different structures, different approaches, and things like that. And we wanted to allow for the sort of local knowledge to go into that. And so that's why we didn't specify, just one type of intervention to do, but instead say, hey, find the best way you guys think to solve these problems and do it. The second piece that I think gets into that flexibility, and this was alluded to as well, is the use of both formative and summative phases of the evaluation. And so for the first roughly half of service delivery, we're doing these rapid cycle evaluations where the goal is not to give a single, yes, no, does this work or not, but to say what seems to be working. Are we seeing trends? Are things heading in the right direction? Do we need to make course corrections? Are there drops, as we go through the chain of identifying people with needs to finding services that might meet their needs, to getting people to services, to engaging in services to meet needs? Are we seeing big drop-offs that we want to hone in on those particular pieces and those kinds of things? And so we use the initial part to learn what's working, what's not, and give plenty of time to make changes before moving into that summative evaluation, which gets closer to the idea of, a more definitive answer about things. And so building in the ability to learn and change and make course corrections to the evaluation, as opposed to just saying that this is complete and fully formed from the start, was really important to our guiding philosophy here.
And moving, I guess, ever more towards the scale version of this, right? The part that takes place across all of North Carolina, that moves outside of the pilot regions at some point in the future. And I would assume that would mean that some of the things that are in the fee schedule will say, and some of them may not be a part of a future program. Is that a correct assumption?
Yeah, I mean, I think the thought is that we wanted to make things modular, so to speak, to the effect, to the extent that you could. So it may be that everything works very well and we want to retain everything. It may be that there's some things that work better than others, and we want to focus in on ones that seem to be working and not. And we wanted to kind of prepare for those possibilities ahead of time in this field. And I, outside of this evaluation, I do a lot of research in this field. I think the fact that health-related social needs worsen health is very clear. There's no dispute about that. We've got lots and lots of evidence about it. But despite how clear that is, the best way to address them is less clear. And so in my mind, there's no doubt that we should be doing something to improve them, but we don't know exactly what. And so we wanted to, part of being evidence-based in this case was really saying, we can't say that this one single way is the best way to do it. We need to expand our evidence base by learning amongst several plausible options, which actually works in practice and can be implemented. And there might be no single answer to that. It might be that in some areas one approach works, and in some areas other approaches work. I mean, there's always going to be that kind of heterogeneity. And so we needed to have an evaluation design that could account for that.
So key message here that evaluation is about learning. We appreciate that. And with that, I'm going to pivot over to you, Laquana, along with the Foundation for Health Leadership and Innovation, where you work. DHHS and Unite Us have been leading this important task of adapting NC Care 360. the referral platform, information sharing, invoicing. We've heard all of this. What are some of the major themes of the feedback that you've received from pilot users? What's working and what's challenging, and how are you acting on that feedback?
So it's grateful to receive the feedback because of the fact that we do have that public-private partnership. We're able to work with a number of stakeholders across the state, especially in our pilot regions. And because of that partnership, we're able to get a number of just feedback that comes in around, one, being in full transparency or functionality. We recognize and know that there are still some things that we still need to work out. There's still some kinks there. For NC Care 360, I still consider us being in a toddler phase. So we are in that phase of really still learning about the platform. How well is it working in community? How well is it working with our payers? How well is it working in our health systems? So with pulling in that information, it's important to make sure that we have that community voice that is there. And maybe later on in the sessions, I'll be able to share some of the things that we're doing to move to that point. But some of the things that we're also looking at is training and education. We have a number of those who have never used this type of technology. Again, this is new. We may have had some other referral network coordination programs that we've had throughout the state, but this is the first one that has been statewide and cross-sectional. So with that in mind, it's important to make sure that we have that training and education in place to ensure that we can continuously teach some of those modules and teach some of those things that may have been foreign to some. And then also just think about network growth. We're still growing the network. And so there is still some areas where we still need to grow in resources. When we think about housing, we have a strain in our housing system. We're thinking about transportation. We're thinking about food insecurity. We're thinking about interpersonal safety. And so we're taking all of those different areas and we're looking at ways to grow those different resources to ensure that we have a healthy network that individuals can not only just use for the pilots, but even going beyond the pilots that we can use outside of that. And so as we continue to work with our different partnerships, we're growing that network. We're looking at opportunities and what are different ways we can look at our functionality? What are some different ways that we can change some things to be able to make things easier? Because if you have the technology and you have someone that's using the technology and you're not in a place where you're meeting in that middle ground, it's going to be very, very hard to implement something on an ongoing basis.
Yeah, thank you so much, Laquana. And as you're talking about resources, I'm thinking part of my experience of this as a community practitioner was that, you know, we need more affordable housing resources, both on the platform, but also in the community. And there's something about having the platform there that's, we sort of knew this, but it makes it even more transparent about how necessary those resources are and the huge gap between demand and availability.
Absolutely.
Ayanna, this is a question for you. This is just a very different way for being a Medicaid managed care organization. They've historically had the authority to offer health-related social needs, but now you'll be paying for these types of services and on a larger scale. So just wanted to hear from you how the pilots have expanded the horizons and the potential of North Carolina's Medicaid MCOs through these expanded services, through data. What's your experience there?
Yeah, we've been grateful for the opportunity to give these added services to our members. The first area I can think of specifically is housing. You know, food insecurity and housing remain two of our top SDOH needs for our members. And what we're seeing in the community. And a lot of times it is really, you know, the resources are out there, but a lot of these community organizations write grant funds and they're tapped with their own funds. And so to be able to offer this service to a larger number of people who can access these organizations, specifically because the funding is there through the pilot, really has been beneficial for our members. And it also has helped streamline the process. Previously, we've noticed too that we can make referrals to community-based organizations. And sometimes, to be very frank, they sit for a minute, right? We're not sure where they go. That closed loop communication is not there. This pilot has allowed us the opportunity to use the NC Care 360 platform for that bi-directional communication and to provide the funding to those organizations so that they do have the capacity, they do have the financial backing to provide those services to members that we may not have seen in the past. And even as our, managed Medicaid offers value-added services, these really help members in addition to. So we offer things, for members as well through, our own individual funding and things like that. But this really just expands the ability for our members to really have the impact on their whole health that they really, really need. We've talked a lot about how these SDOH needs really impact their health, the transportation. getting people back and forth even to pharmacies to get the medications that we have now prescribed, right?
Mm-hmm.
You know, they're getting out of the hospital. They need that transportation to get to the grocery store when they're now placed on a heart healthy diet, you know, and things like that. So being able to tap into the funding source and the technology platform at NC Care 360 has really been invaluable for our members.
Thank you so much, Ayanna. And I'm going to turn to you, Amanda. We've got about 4 more minutes for the whole panel, but we've got a couple of audience questions that we're kind of smooshing into this question for you. We want to know what's next for the pilots as you approach the end of the current waiver in a little over 2 years. And an audience member is specifically asking, is there room for expansion to other parts of North Carolina? And if you could also go a little bit into a question about data, HSOs and clinical data and so on, and what might be next in terms of the integration of that.
Yeah, sure. So the department has submitted a request to CMS to extend our 1115 waiver through the end of June 2026. So that it can still run for the full 5 years as it was originally intended. So we're hoping to get approval. And so hopefully we'll have a little bit more time than just the next couple of years. But in the meantime, right now we're working on standing up our pilots for our tailored plan members. We're also hoping to get our tribal option members access to the Healthy Opportunities Pilot Services. So we'll still be standing those up in the next year or so. But then I think, and as Seth alluded to this as well, the goal, if we're able to show that some of these services improve health outcomes and reduce healthcare costs for our beneficiaries, that we would then be able to include them more as traditional Medicaid benefits after the pilot is over. And at that point, we would be able to offer them as statewide benefits rather than in just our 3 pilot regions. So that is the goal. I think, you know, and we are clearly hoping that we're able to show positive evaluation results and do that. I do think that ultimately something, regardless of how those evaluation results turn out, is that we're hoping that the infrastructure and relationships that we're building through the pilots, through the health and social services sector, can sustain themselves after the pilot period is over. Hopefully that will continue to remain in place. And I think a lot of that is in the data and technology transfer. So of course we have NC Care 360 that's being used for our enrollment, service authorization, referrals, and invoicing for the pilots. So that information then again gets turned into an encounter and is sent to the state, and then we're able to merge. So we're able to merge our claims data basically for medical and non-medical services and look at that holistically, which I think it is huge, so that we're able to have a much broader picture of a person's health. And so I think developing that infrastructure to sustain after the pilots will be really helpful.
Thank you so much, Amanda. All right, so now we're at the 15-second answer category. This is the bonus round and the buzz in. Addressing social needs as part of a more whole person approach to care is one of the pilot's policy designs with a focus on improving health equity. So remembering one of the big whys behind this, it's efficiency, effectiveness, but it is also about equity. In 15 seconds, waving your magic wand, what would you recommend to other states to achieve equity through health policy programs to address social needs? Who's first? I see you revving up, Seth. Okay, go ahead, Seth, and then Ayanna. Go ahead. 15 seconds.
I'll go first. And in 15 seconds, I would say, think beyond health programs only. So I think the work that we're doing here needs to occur, and I think is likely to improve health and hopefully will improve other health outcomes. But in parallel, many of the equity issues that we face are the results of other social policies. And so we need to be deploying all the tools we can, including social policy and many other spheres, along with health policy.
Thank you, Seth. Ayanna.
I would wholeheartedly agree, and really understanding the needs of your communities and the gaps that exist, and truly really understanding how you want to impact those gaps. on a more finite level than just saying housing, right? What is the housing need and how are you going to address those needs for your specific community?
Appreciate that so much. Laquana, what about you?
Invest in the infrastructure of your community organizations.
Mhm.
We really depend on a number of our community organizations to support a number of these different, programs and projects. And so if you don't have that in place, these organizations aren't able to move forward and have the resources that they need to do the work. So I say invest in community.
Yeah, and interestingly, sometimes the more of an HSO provides, the more it loses, right? So recognizing that piece of it, just economically, of course, it's important for the community. We'll go to Amanda, and then Will, you'll finish us off. Amanda, 15 seconds about health equity guidance.
Yeah, I would just say to be very intentional and proactive in trying to do it. We have some enrollment and spending requirements that enrollment and spending on pilot members reflects the demographics of their Medicaid population in the community to try to get at member health equity. And we're also finding that many of our CBOs that kind of raise their hand first to participate in the pilots are some of the larger ones with more infrastructure. And so we're really trying to take community feedback and be proactive about how we can include smaller, historically marginalized led HSOs.
Really important. Thank you for making that point. Will, to you, and then we go to a break.
Yeah, and just quickly from studying a lot of different programs that work on addressing social needs through health policy, there's a lot of great approaches out there. And I think what I appreciate the most about the pilots, which I think sets it apart, is it's not something you can do to address social needs. You must do it. Folks in Medicaid are being screened. They're required to be screened. And then when they have a social need identified, that must be addressed. So that direct requirement, which I think is a unique feature of this program, I think is really important for equity.
Thank you for that. I want to thank all of our panelists. Amazing work that you're doing. I want to thank you both for being a part of the panel today, for your looking back and sharing your lessons, but also just for the work that you're doing and this important just the important getting right in there and having the courage to do it and share it with us. We are going to go to a break. Will you let me know? Are we going to take the full 5 minutes?
Why don't we do 3 minutes and come back at, like 10:51.
That's a stretch break. It's a run and get a glass of water break, and we'll see you back at 10:51. Thank you so much.
All right. Well, thanks everybody for sticking with us, and appreciate your coming back after a short break. I'm Rob Saunders. I'm the Senior Research Director for Healthcare Transformation at the Duke Margolis Center. And my job here is to talk a little bit and help moderate a panel looking at some of those regional and community perspectives on the pilots. And so excited to be able to do that. I'd like to encourage folks to keep the questions coming. There's been a great series of questions already, and I've already started to weave those into the questions that we'll ask the panelists, but I'll keep my eye on the Q&A bar and make sure I incorporate new questions that come in. So one of the goals of this panel is really to think about the beneficiary experience and really center ourselves on how the Healthy Opportunities pilots are not just a policy innovation, but really are having impacts on real people in North Carolina. So I'm going to kick this off, turn it over to my colleague, Will, who's going to share a little bit about what we've heard from some of the beneficiaries who've been able to take part in the pilots to date. And then I'm going to move things to a panel that's going to really go in depth on what folks are seeing. So Will, just share in a couple minutes about what we're hearing from folks who have been able to join the pilot so far.
Thanks, Rob. Just for background, we conducted 2 focus groups. We actually captured some folks in the first 8 weeks of the rollout who had received services, and they represented folks from a variety of backgrounds, including geographic variation and variation by rurality, race and ethnicity, age, sex, and family structure. Just wanted to note these were conducted in early May, which means that we only captured food box rollout for these particular beneficiaries, but we did ask them about more than that. So actually, I wanted to start with a little mission moment and say that one clear finding from the focus groups was we heard time and time again, people were really, really appreciative, overwhelmingly appreciative that they had the opportunity to receive food services. We did not design our questions to draw that out specifically. People were very forthcoming with telling us about their immense gratitude. One thing we heard about the awareness of the pilots among beneficiaries was that they learned most commonly about the program through their Medicaid care managers, which is not surprising because that's part of the enrollment process. But there were others who heard it from interactions with their doctors or clinicians and by word of mouth. And lastly, we heard that a few of the participants were suggested to enroll in the pilot service programs because they didn't qualify for other programs like SNAP. And since they didn't qualify, they may have never heard of the program if it weren't for Medicaid, which was something they expressed. And even if they did receive food services, services like food stamps, we also heard that those services were limited. And if the food insecurity needs were not being met, then HOP would still step in. I'm actually going to skip the clinician interaction slide because I want to get straight to some of the feedback on the services quickly so I can get to the panel. So just talking a little bit about food services, folks really liked the variety of what they had. We heard funny stories about people getting a lot of a particular food item that they never cooked, like a zucchini, but then having fun learning how to cook that food. So there was learning opportunities there. We also learned about a little bit of opportunities for improvement. Some things to talk about would be better communication about what services are actually available. A lot of the folks had only heard about the food box delivery and they weren't aware that there were other services, which could be an opportunity for actually sticking information right on the boxes for some of those services. And accordingly, in terms of choice and variety, there were folks on different ends of the spectrum. So some people wanted, more access to fresh foods and hot meals. Others wanted more canned goods, and opinions varied across the board. So not too surprising there. We did ask a little bit about the other domains, and I want to hit on those quickly. Just as a reminder, these recipients had not received these services, but they gave interesting and helpful thoughts on what they might want to see. In terms of housing, we heard for people with disabilities, housing would be an important housing supports would be an important source of stress relief for them. Folks really wanted AC and heating repairs as an option, which I know right now is something that the pilots are thinking about, but not a current service. Safety modifications in the house. We heard a request for expanded services like roof and ceiling repair or unresolved hurricane damage, which is a big thing in the eastern part of the state. And then lastly, a lot of the housing services were geared more towards renters. And so folks wanted some supports for homeowners. And quickly on transportation and some other services. So we did hear about a public transportation gap from pretty much all of the folks we talked to, which means that personal car flexibility for using transportation services would be really important. Uber and Lyft and other private contractors are an option, but again, there is sometimes a lack of access in rural areas. So it begs the question folks were asking, what if my family member owns my car and it's not me? Can services be authorized for that car? These were some of the things we heard. And finally, on relationship and stress services, people were really appreciative about the ability to talk about these things. There was also a little bit of hesitancy, which is just important to note for clinicians. Depending on where the person is, there may need to be some careful wording if there's family with them, right? Breaching those conversations can be challenging. And beyond the services that are offered in HOP, we heard some folks saying that they would love more of a general sort of life empowerment services. So not necessarily related to stress, but like, how can I improve my own motivation? How can I get connected with job training and skills training? So I wanted to stop there and kick back to the panel, but this was some of the feedback we heard from actual folks that were receiving services from the pilots. And back to you, Rob.
I really appreciate it and appreciate the ability to kick this off by hearing from folks that are actually real people who are actually being involved with the pilots. We got a great panel here today. In the interest of time, I'm just going to share their name and affiliation, but the full bios are in the meeting materials. So I'll ask folks to turn on their camera as I call them out. So kicking off in alphabetical order here, we've got Dion Greenlee-Jones from Impact Health. We have Emily Hart, who's joining us from Catholic Charities from the Cape Fear Regional Office specifically. We have Madeline Moriali from Legal Aid in North Carolina. We have Sarah Rideout from Community Care of the Lower Cape Fear, and Melissa Young-Rupe from Access East. So if we can have everybody there, and Perfect. Everybody's on. And so similar to our last panel, I'll ask folks to limit themselves to a minute or two so we can get through as many questions as we can. But I'd like to kick things off really talking about maybe some successes that folks have seen, recognizing we're very early in the pilot process, but there have been successes here so far. And I maybe we want to start with our network leads who have been doing amazing amounts of work over the last, well, many months, putting things together so that we could have a successful launch. And maybe start with you, Dion. You know, what's been a success that you've been able to see through the pilot so far?
I think one of the things that's been amazingly successful is our intentional and the building of the network with diversity, equity, inclusion, and consideration. One of the great successes is how could we empower even smaller community-based organizations or HSOs that aren't often brought into the mix when it comes to being valued as stakeholders in a lot of conversations. So that's been really empowering to see how we can support smaller organizations to do this work in a way that has never been done before. That's also including a diversity then of different organizations that we haven't always seen in these type of initiatives, approaching faith-based organizations. You know, oftentimes churches and faith-based organizations have not always been included in conversations where the joke is, or the serious part is that they've always dealt with social determinants of health, but have never always been a part of these partnerships. So being able to do that has been really empowering, because it also has set kind of a model for even our larger organizations that are seeing different service models. For example, a larger organization, a food organization, being able to not just provide food boxes, but designing those specifically to the needs of those that need them, which is neat, personalized attention. And then they're being able to interact on a larger scale with community organizations and individuals they're serving. And then I have to say that we're just also excited that Impact Health was the first network lead that received referrals, and then the first to provide reimbursable services. So those were great successes. It was a great launch party day to see the launches happen, and then immediately for us to get referrals. That was indication that the model is working. You know, it's successful already in the early days.
That's great. And I appreciate your early point as well, which ties us back to the first panel of really how do we intentionally think about equity as we're designing a lot of these networks. Going through my screen here, Melissa, I'll turn to you here. What's been a success that you've seen from the Access East perspective?
From our perspective, the biggest success that we've really been able to see is the delivery of services to the community members that need those services. Many of our HSOs have been in the communities, but especially after the COVID pandemic, they were really struggling and really had taken many of their services down and were not able to serve the people that they had served before. So being able to assist them with capacity building and allowing them to really rebuild their structure to be able to serve the community has been huge. When we see the stories from community members who come up to pick up the food and they're just in tears because they were trying to figure out how they were going to get to their doctor's appointment and afford their child's medication, and they weren't sure how they were going to feed their family. That is the most rewarding thing that we have been able to share with our HSOs, is really seeing the service delivery and helping those people who really have needs. In our rural Eastern North Carolina area, the COVID pandemic really impacted us significantly. And some of those HSOs really were not sure they were going to continue to function. So being able to work with them hand in hand and really begin that service delivery has been the most impactful success we've seen to date.
Great. Sarah, turning to you next, what's been a success that you've all seen?
Yeah, I would agree both with Melissa and Dion. I mean, everything they said really is the same thing here in our Lower Cape Fear region. I think another thing to really add is just really seeing things coming together. We had HSOs, again, that are really working together and sharing best practices and what's working and what's not working when we're trying to meet the needs of our members. If, you know, there's any type of kind of concern or issue, things like that, you know, they're coming together to really share those best practices. And then, of course, just the collaborative efforts of everybody involved with the health plans and the network leads. I mean, as the network leads, we come together to also share best practices, what's working, what's not working. And then, same thing with the health plans and with DHHS. So beyond just what Melissa and Dion already discussed, I think that collaboration and everybody really trying to work successfully together when there are barriers, and that's why we're here. We're here in a pilot to meet the barriers before this scales, right? So, we want to hit some of those barriers and problem solve in real time.
That's great. And Sarah, Melissa, and Dion are coming at the Healthy Opportunities pilots from the network lead perspective, but we also wanted to bring human service organizations, our HSOs here as well, because they are directly delivering many of these services and directly working with folks. And so for Emily and Madeline, I'm going to maybe take the success question, but also weave it into, what have you seen on the ground? I know we're still continuing to phase in service delivery. So some services you've been able to deliver, some you are on the precipice of delivering, but would like to hear from you. What have you seen the impact of HOP on people's daily lives, and are there particular challenges that you're seeing as you do that? So Emily, maybe I'll start with you and then go to Madeline.
Sure, thank you so much. So I think one of the successes that we've seen on the ground is we're able to connect with people who are referred by their care manager and really give them a tailored food box. So Catholic Charities is contracted with to provide 6 services, all within the food sector and the housing sector. But I found that we are providing much more than healthy food boxes. When we call families, we're asking them what are their likes, what are their dislikes, as well as do they have any dietary restrictions? Or do they have food allergies in the home, things of that nature, so that we can, we have the flexibility with this program to create boxes that are meaningful for each and every family. And then there's an added part to this. When we're delivering these boxes, we then have someone who's stepping into these families' homes, who's laying eyes on them and their health, what they look like, but then that touch point, right? Some of these individuals are very isolated. So it's great for our delivery drivers to be able to connect with individuals. So as I said, we're nourishing much more than bodies through this specific service. And one of the things that I think has also been successful is, once we're in the home, then we can come back to the care manager and say, hey, out of these 29 services, perhaps this family could benefit from some other services. Could you rescreen them and kind of find out if there's any other services that they might benefit from to get them even healthier?
Thanks, Emily. Madeline, turning to you.
Yes, good morning, and I apologize, my affiliation, I can't remember how to do that. So I'm with Legal Aid of North Carolina. The successes I'm going to identify are sort of, some of them works in progress. So we're a cross-domain service, which means we're in 2 domains. We are in housing and we are in IPV, toxic stress. And we are one of the, maybe one of 2 organizations that is pleased to be able to work in all 3 regions. And although our services haven't not yet launched, we are very actively participating in each of the network's convenings. I don't think we've missed a single meeting in any of the 3 regions, and it's not just me, it's another larger group of staff. But we learn from each other, we support, we hope we're supporting the network leads and other HSOs, not for only by virtue of also being in the other regions. In terms of a success to date, I want to identify one that's a work in progress, but I think it's really important and really difficult, which is the work we've been doing with the department and the North Carolina Coalition Against Domestic Violence and pro bono partners and many other key players to really do the very hard work of trying to figure out how to keep that IPV domain here and active and also in service of the other sensitive service populations. There's just, as others have said, really challenging issues around safety, privacy, and confidentiality. Before the service definitions were actually submitted to CMS, someone asked, is it really just that hard? And we all said, no, it's hard, but it's really important. And we rolled up our sleeves. I think thousands of hours in good faith have gone into this, and we're looking forward to being off the precipice and actually on the ground.
Thanks, Madeline. So one of the key parts of the pilot phase is really the network building, and that's the network part of network leads. How do you put together a network of human service organizations that is able to work together, that is able to take referrals, that is able to have that two-way communication? And there's a lot of variation between the pilot regions, but it's not as if each pilot region itself is homogeneous. You've got a lot of heterogeneity within each pilot region. And some of the audience questions here have asked about building that network. There are specific challenges in rural areas where there may be fewer human service organizations, or it may be much more challenging to deliver services because of transportation. There may be internet issues. Dion, you already flagged the equity issues as you're thinking about building the network. And one of the other audience questions was thinking about that balance between new and existing human service organizations, and how do you make sure that you respect existing organizations while recognizing that there may be a need to build capacity in certain areas if you're going to meet the needs that are there. So maybe turning to each of you, recognize I gave you an enormous amount of question, and you get about a minute or two, to just say, what's been the key learning, or the key thing that you've taken away from this network building work as you've been able to do it, that others should think about, especially as they're thinking about other states implementing similar HOP type services. We'll do reverse order. Sarah, maybe I'll start with you to see what's your biggest takeaway here.
Sure. So I think it's really important to really think about the organizations already in place, including the network lead in the regions, right? Because a substantial amount of work really took place when we were preparing our submission as network lead. Community Care of the Lower Cape Fear has already served in our 6-county region for 19 years. We've been screening for social determinants of health and connecting members to resources. So we were really able to build on those relationships, as well as kind of make new relationships in this process. When we became the network lead, we put a team together that consisted of program managers experienced in each of those sectors, as well as care council leads that really champion specific counties and are able to provide that technical training and support. And then we also had an implementation team that consisted of, again, CCLCF, we had Cape Fear Collective, New Hanover Regional, and UNC Wilmington. And that really helped us expand our reach to HSOs across the region. Because as Dion mentioned previously, there are a lot of wonderful anchor organizations in our region. But there's also a lot of HSOs, maybe in rural counties or in other areas, that maybe have never been invited to the table before. And we really wanted the opportunity to have HSOs that are really rooted in their communities and are trusted supports. So there, like I said, there was a tremendous amount of time invested in working with HSOs in the beginning, really to help understand, what services they already provided, what infrastructure was already in place, and then what capacity building was needed to really help them provide services in each of those counties. And again, that really is different, right? If you're in a rural county versus an urban county or even tract, those capacity building funds really helped build up the infrastructure of those HSOs. And, just in terms of like service gaps, we kind of have a living matrix where we can already, always see where our gaps are in services and how we can really either have HSOs expand in their service areas or invite new ones to the table.
Thanks, Sarah. Melissa, turning to you next, what was your biggest takeaway in building these networks?
I would agree with what Sarah said. Access East had already been very active in the full region that we served. And so we selected 9 counties based on input from some of the key leaders from those organizations when we submitted our proposal. Pretty quickly after we found out we were a network lead, we began to form our governing body to oversee this work and developed a rubric which included many of the key things we wanted to look at. Which organizations already were providing services, which organizations had missions that were more aligned with the work that we were going to be asking them to do. We did look at health equity and which organizations were minority owned or women owned and how they were interfacing with their community. And then we included representation from the actual community. With some of the work that we already had going on, we had community members who were great at giving us feedback and knew who were the sources to provide trusted services in their community. And I say that because not always was the biggest organization the best organization. We really looked for the organizations who had the trust of community members and helped them with the capacity building they needed to be able to provide those services. So we looked for organizations that community members felt comfortable with, that they trusted, to really bring those people on first, because we knew that if the community members trusted them, they would be willing to access those services in a way that would be much more productive than a large organization where they may not have had that much trust. And so I would say the biggest piece for us was getting community feedback early and often, and continuing to incorporate that feedback as we add on HSOs. We do, as Sarah said, keep a running total of where we have coverage, where we need ongoing coverage. That piece we're continually looking at and continually accepting applications and talking with those community advocates or liaisons about which organizations in those communities they feel would be most trusted by the community, and then working to get them up to speed.
Thanks, Melissa. And Dion, take us home. What was your biggest takeaway in putting together the networks that you've done so far for Impact Health?
Well, one of the things that's interesting for Impact Health is we're actually the youngest organization of the 3 network leads, but that doesn't mean that we didn't have great relationships and what I like to refer to as relationship capital in Western North Carolina. We serve 18 counties, including also in addition to the Quala boundary. And so what this meant is that our founding partner, Dogwood Health Trust, in the initial proposal also had over 100 letters of intent from all kind of organizations, diversity-wise, throughout Western North Carolina. So that already allowed us to build upon that, which meant we had a huge diverse group of organizations expressing interest. Now we're up to around 50 HSOs that are part of our network. Also, though, we looking at I agree with Sarah and Melissa here about the capacity of the organizations that have applied. You know, we did readiness assessments to see where organizations were, to understand what their needs were, and how it didn't mean that a no, we didn't have no's. We rather had, how can we help you get ready for the pilot? How can we help you with technical assistance? How can we help train you with NC Care 360 and NC Tracks and other platforms that you would need to be able to utilize to be successful on the platform? And we also were able to use data at an early stage from NC 211. We were able to have guiding, again, colleagues at HMA and Savinia who helped us with our dashboards and determining where those gaps were. As everyone said, it's important to look at always updated data on a regular basis. So we were able to also and continue to use that when we look at gaps. And really listening to our community organizations. The communal knowledge is so important for our HSOs, community-based organizations here, and being able to really look at a different model of subject matter experts, a hub and spoke model. If we have a couple of leading organizations, one in the food domain and another in transportation, larger, who have deep footprints throughout Western North Carolina, and they help serve as also a guiding force for other organizations cross-domain or in those specific domains, acknowledging that we have subject matter experts in the region. So we don't always need to go elsewhere. We can look right in our backyards to have that kind of information sharing amongst all of our partners. So it's been exciting to create community collaboratives and all types of training and facilitation to make sure that our HSOs, community-based organizations, understood that they would be supported. Because again, as other panelists have spoken to, we've been asking them to serve as billing entities. And this is something that could be determined as a big leap if you've never done that or operated in this space before. So a lot of this is really fortifying those relationships and then making sure that we continue as we grow, utilize those relationships. How do we expand into neighboring counties? Perhaps you are able to provide services in other counties. So we look at all of those factors. And again, of course, equity, through an equity lens to determine how we are growing, continuing to grow the network.
Thanks, Dion. And, I think the takeaway I have here is that there's an amazing amount of work that all of you have done over the capacity building phase. And for other states who are interested in launching, say, something like HOP, to not underestimate the amount of work it takes to do this capacity building. But that's not to say that it's not possible. I mean, we have examples where folks have been able to do it. It's just, it takes a lot of work and effort and sweat to make it happen. One of the audience questions, and I'm going to turn to our HSO colleagues here for this, is about how have HOP changed maybe the relationship between the healthcare organizations and the human service organizations. In the past, there were some relationships, but they were typically ad hoc. Folks sort of saw each other maybe, across a community, but they didn't necessarily have close relationships. And, there's different cultures between the healthcare world and the human services world. There's even, as Dion, as you mentioned, different billing or different approaches to thinking about finances versus, maybe more grant on the human service organization side versus, a fee-for-service billing that's very common on the healthcare side. So maybe Emily or Madeline, if you want to grab this, have you seen your relationship with healthcare organizations change during HOP, recognizing we're still early? We've only been in this for a few months here, but any changes that you've seen in those types of relationships? Madeline, I see you went off mute first. Do you want to kick off?
Thank you, Dr. Saunders. So Legal Aid of North Carolina, we serve all 100 counties, including the 33 HOP counties. I have directed since 2008 our statewide medical legal partnership program, which has been working with clinics, hospitals, and health systems across the state to integrate access to free legal services into their efforts to, enhance equity, reduce disparities, and address the social drivers of health. So in that regard, we sort of came to HOP with some experience about closed loop referrals and, how do we get better health outcomes and better legal outcomes because we're working collaboratively. So in that, but now we're doing it at scale, right? As an entire organization and with far bigger populations that we'll be able to be serving. I think this is both a success and a sort of transformation, but multi-sector collaborative efforts, that is not familiar ground for a lot of folks. We're accustomed to working in our skill set, in our silos, and it really takes a different kind of investment to understand each other. This will work best when the PHPs understand the value of the services, when the care managers understand how to go from a positive screen to actually connecting people to services. And there aren't a lot of healthcare payers or providers that are accustomed to thinking about HSOs as collaborators instead of refer out over there, hope it works out. And so this is going into concern and maybe too long, but at this point in the early stages, there's far more work to be done in terms of enhancing communication at all levels within the pilot and also training at all levels within the pilot to really ensure that those who are eligible and need the services get the services. And I'll stop there.
Thanks, Madeline. Emily, do you have thoughts here?
Yeah, definitely echoing what Madeline said. I think that in the past, social services and the healthcare world have kind of acted in silos where we might make referrals to one another, but not know exactly where those referrals might have gone. And this is a really unique and beautiful opportunity for us to be collaborating together from two different fields where we can really serve the whole person and really take care of the whole person So I just think that it's been a really unique opportunity to be able to do that and collaborate around that, and to have conversations around that, because all of us have very different expertise. So I think it's been really important.
Right. All right, so for a time check, we have 2 minutes left, and I'm going to take a page out of our last moderator's book and do a rapid fire ending question for each of you, which is, if you had a magic wand and you were helping, let's say, another state help launch something like a hop service, what would be the one recommendation that you would give to help that other state to be even more successful than North Carolina has been so far? And so to kick us off, maybe, Dion, I'm going to turn to you. You've got a magic wand in 15 seconds. How would you help another state?
I think the magic wand would be us looking at capacity of not just HSOs, but other stakeholders. For instance, care managers. When it talked to, we're now meeting with PHPs and care managers in the same spaces. We also understand that perhaps they have staffing issues. Perhaps they are not trained yet as everyone else has been trained, or have not received as much training for NC Care 360 or the platforms or any of the rules and regulations here. So we're trying to also make sure that we're supporting care managers and other stakeholders so that all of us have the capacity to really be successful in the pilot. If care managers can't help with the referrals, then folks don't get the services they need. And that would be one of the suggestions, that everyone should be evaluated for all of their capacity needs, and maybe there be additional funding or other resources also shared.
Well said. Sarah, turning to you, if you had a magic wand in 15 seconds, what would be your one recommendation?
I think really this is an opportunity to be innovative. It's really easy to say, it's always been done this way. And that really just does not work with this type of pilot and program. So it really does require a combination of being methodical, and data-driven, administrative, but also collaborative, using innovation and being flexible all at the same time. I mean, we know with COVID that really did kind of hinder, at least the pilot at some point, and then we had to really kind of move forward. And so a lot of that flexibility and innovation was key.
Thanks. Melissa?
Yes, I would say intentional knowledge of the community and the people you're trying to serve, as well as intentional and early collaboration among all of the partners, is the best way really to kick off this program.
Thank you. Madeline, how about you?
I would say it's the importance of early investment and helping all players understand the roles and the stakes that HSO, human service organizations, have in value-based care. We've talked earlier about, it's one thing to go from grants to fee for service or even per member per month kind of reimbursement. That's a big wow. But to be able to adapt and scale up is not a small challenge for most organizations, even statewide ones like ours with a long history. But to be able to do that it would be really helpful if we knew earlier on some guesstimate about potential referrals, because without that information, it's A, hard to put together a capacity building budget, and B, hard to figure out what your staffing model is, because you don't know how many people on a fee for service versus grant model you need. And so I would just encourage a quality improvement approach. There's a lot, we have a lot to lose, right, if we can't demonstrate our value. And so, we're worried that the CMS evaluation really isn't set up to do that for the HSO perspective. And, I hope that in the end we can prove value, but I'm not quite sure how we're going to know that, even if we're all successful at what we do.
And Emily, you have the last word.
Thank you. So echoing flexibility and creativity, and always being mindful and sharing best practices with your partners in the field, I think is really crucial. I know in the early days, we had some challenges during the capacity building phase with things like food sourcing when there's food shortages, or even identifying subcontractors. A lot, especially in the Cape Fear area, most contractors are taking only multi-million, billion-dollar deals. So how do you find the subcontractor that's willing to do a $500 or $2,000 job? So really being creative in those solutions and identifying potential like small local business owners and partnering with them. And then, so yeah, creativity, flexibility, and making sure we're always evaluating our services.
Well, I'd like to thank the panel today, not only for their willingness to share this information over the last 45 minutes, but also for the work you're doing. And I'm going to turn things over to Kathy Colville from the NCIOM to close us out.
Thanks so much, Robert. And to your amazing panel, I feel like I'm 576% smarter than I was 90 minutes ago. We've all taken in so much information. I'm going to share some last reflections. I think we're going to put up a slide here. I want to emphasize for policymakers in other states and settings interested in health policy, we hope that you'll connect with our partners at the Duke Margolis Center and with their research team to chat further. And all of this information is here, and we'll emphasize that slides and recording will also be on their website and shared with you as well. So I think we can take the slide down for a second, and I'll just share very brief reflections. First of all, I want to emphasize something that Will noted, and we heard from so many others. There is a deep need, and this is tapping into a deep need for these critical services, and that services like food and transportation are a necessity, and they're also a multiplier in order for health services to be effective. Second, I wanted to emphasize that these pilots are not designed to implement a predetermined model. They're designed to amplify learning and empower these leaders that you heard in their solution seeking. And because of that, this third reflection I want to share, this required element of trust and empathy that these learners and leaders are showing with each other and with our systems and sectors, health, housing, law, social services, violence prevention, and more, that we're all designed to serve people, but have very different histories, influence, and systems that they've developed in order to do that, and need to be knit back together in order to integrate in the way that's required of this work. Finally, I'll just share, I was so tickled by Will's comment about people being excited about zucchini. And as our gardens come into season, I will all share that we are all at this moment trying to figure out how to prepare zucchinis for our family. And we appreciate that that's true across the board. The final comment I just want to share is to return us to the why. Everyone that you met today knows personally or professionally what it means to do without, what it means to do without or go without health insurance, without food, without housing, and without safety, and hopefully not consistently, but temporarily, but even then it's difficult. And so because we know the depth of that, we are all working alongside you, rolling up our sleeves and desperately interested to help make this, learn the most from it so that we can serve our state and others across the country as well. Again, thank you everyone for participating. Look for more information in order to get the slides and the recording of this, and we hope that you'll be interacting with us in the future. Thank you.